Bonjour,
Bonjour, bonjour. Ça
ça
va?
va?
Oui,
Très
ça va.
bien.
Un peu fatigué, mais c'est dans la thématique.
Oui, c'est une inspiration.
Voilà. Euh, donc, le son fonctionne bien.
Oui, est-ce que tu
L'image.
veux essayer de partager ton écran, s'il vous plaît?
Oui.
J'arrête mon partage.
OK. Alors, il faut que je sois plus grand. Alors, écran partagé, on va mettre ça. Partager. Est-ce que ça fonctionne?
Parfait.
Super. Donc là, moi, quand je fais ça, je n'ai plus que deux petites images. Parce que mon deuxième écran vient de briser.
Ah bon.
Ouais,
Et quand
juste.
même, tu peux choisir le layout. Il y a des layouts qui montrent plus ton slide, ton
OK.
diapo et que réduit l'image tu peux même n'avoir pas d'image quand même.
Oui, c'est ça. Je vais laisser quand même un petit peu
OK.
dans le coin là pour au moins t'avoir toi s'il y a des réactions que tu veux me montrer. Parce que est-ce qu'on accepte les questions pendant la présentation ou après?
Après, elles
OK.
sont écrites dans le Q&A.
Hmm.
Et à la fin, je vais déverrouiller le micro de tout le monde, c'est-à-dire tout le monde peut te mettre les questions en direct.
Hmm.
S'il y a quelqu'un qui a sorti ou qui ne peut pas parler, je lirai la question. OK?
D'accord, c'est parfait. Mais juste, c'est ça, je ne verrai sûrement rien à part toi pendant la présentation. Donc, s'il y avait
Non.
vraiment une urgence, tu me fais des
Oui,
signes,
oui,
hein?
oui, oui.
Merci.
Pas de souci. Je
Parfait.
ferai ça. Pas de souci.
Est-ce que je laisse le partage comme ça ou
Oui,
j'arrête?
oui, pourquoi
On
pas,
peut
oui.
laisser comme
Oui.
ça? D'accord.
Et comme ça,
Quelle heure il est? Bon.
on peut, on peut oui,
Hmm.
c'est comme ça.
Oui, quel terme? Je suis désolé, hein, je suis à la dernière minute. Which term would you say in English for modafinil? You know, like, is it
It's
withdrawn?
modafinil.
No,
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 it's
sorry. About the situation now in Europe, is it restricted on the list of restricted drug, or what is the exact name? You don't know?
it varies. In
Okay.
England, you wouldn't be able to have it except if prescribed by a neurologist. Here in France, I don't know the situation regarding modafinil at the moment.
Okay.
Uh, I'm not doing sleep clinics here at the moment, so
Yeah.
I don't
Okay.
know. Yeah.
No, no problem. It's just because yeah, I can say that the situation is variable in Europe, but it's not so easy to prescribe it. No, so anymore. Okay.
So we already have 3 attendees. Just to explain that we haven't started yet.
Yeah.
Uh, in
Okay.
fact, it's 2. So
They are already with us.
yes,
Okay. Sorry about
yes,
that. So.
no worries. So we'll wait now 5 minutes more or less, and afterwards we'll start it. Okay.
Mhm.
Okay.
Thank you.
Thank you. I don't know if you met Terezinha Benjamin. She's the coordinator of the RN. You're muted. Tu es muté. You're both muted, so if you're trying to talk, you have to unmute yourself.
Yes, okay. Sorry, I forgot I muted myself. So hi, nice to meet you, Regina.
Nice to meet you also, and thank you for giving this this webinar.
You're welcome. So, Pedro, thank you for the the occasion. It's always a pleasure. Thank you.
There is a message from Mario Gomes Pereira in the chat.
Yes, because I poked him when he arrived.
Sí, espero.
He wishes us a happy new year, and
that we are good.
Hopes that we are
fine.
Well, mostly Antonio. This is the Portuguese team here in Paris.
Yeah. But bonne année to Mario. I think I'm gonna close the chat now because I can get unfocused.
Yes, I'll do the introduction in 2 minutes and then we'll start.
No problem.
There.
Yeah.
Okay.
Thank you.
Okay, so welcome to this Euro-NMD webinar about sleepiness, fatigue, and apathy in DM1, so myotonic dystrophy type 1 patients. It's delivered by Dr. Benjamin Gallet from ECOBES, Recherche et Transfert, et Cégep Jonquière, amongst other affiliations. He may specify that later if he needs. As you know, the webinars format do not allow you to speak during the webinar, but you can use the Q&A question and answer tool so that you can put your questions by writing. At the end of the webinar, you will be unmuted and will be invited to voice your question, or if you're not available anymore, I will read it. And that's basically the rules, as you know. So I'm going to speak a bit about Benjamin. He obtained his doctorate in clinical psychology from the University of Paris in 2010. He's a clinical psychologist that has a postdoctoral internship in the interdisciplinary research group of neuromuscular disease in Saguenay, where he had the epidemiological opportunity of meeting many patients with myotonic dystrophy. And so he had a very prolific field to develop his research. He is quite interested in characterizing the personality and the impaired cognitive functions of neuromuscular diseases, namely of myotonic dystrophy, their evolution and their impact on the autonomy and social participation of the patients. So his work focuses on the consequences of damage to the central nervous system. So fatigue, motivation disorder, sleepiness are main axes of his investigation. And is also interested in the mental health of college students and how it's impacting their academic success and perseverance. Since 2018, he's been in the EcoBase team. And so I have to thank Benjamin for his kind acceptance to deliver this webinar. And I will pass the floor on to you. Thank you.
Thank you so much, Antonio, for the presentation and for the opportunity to present this very interesting topic. Hello, everybody. So let's start with this webinar on sleepiness, fatigue, and apathy in DM1 patients. Just the sorry, because Antonio already did that. I just wanted to present myself so you understand why. I mean, what brings me here in front of you today. So presently, yes, I'm a researcher at ECOB in Jonquière, Saguenay, and associate professor at the University de Sherbrooke, associate professor at the University of Quebec at Chicoutimi. And yes, as you said, Antonio, I'm a member of the GRIM. GRIM is pretty famous in the DM1 field. It's a research group here in Saguenay, led by Professor Cynthia Gagnon. And I'm also a member of the, it's a research lab focused on health innovations. And I just wanted to say that I used to be a clinical psychologist at the Institut de Myologie under the direction of Professor Bruno Aymar. So I've been there for during 7 years before to leave for Saguenay. But I mean, this clinical experience that I had with neuromuscular patients, you know, bring me many inputs, so I can, you know, that I'm still using in my research, of course. So very briefly, because I'm sure that everybody knows about DM1, it's an inherited neuromuscular disease, and it's the most frequent NMD in adults. And basically, it's divided in 5 phenotypes based on age of onset of the symptoms. And I'm just saying that most of the studies that I'm presenting today are focused on adult classic phenotypes. Sometimes studies have mixed juvenile and adult classic, sometimes late onset and adult classic, but so it's more about these phenotypes rather than congenital or infantile. And as you may know, it's a very multisystemic, slowly progressive disease. And among the systems, we will focus on the brain. Brain leads to neurobehavioral symptoms in DM1. And so there are, you know, cognitive manifestations. I'm doing many works on these symptoms too, but it's not the topic today. So on the behavioral manifestations related to the CNS, we're going to talk about fatigue, daytime sleepiness, and apathy. So the clinical symptoms and their impacts. There are sleep disorders. So sorry about that. I made a rapid run on the literature review. Of course, it's not exhaustive. There are many studies in this field. But what is clear, we can say that there are sleep disorders in DM1. It can be SRDB, you know, obstructive and central types, or PLM, or even REM sleep dysregulation that has, you know, many studies. I only referenced a few of them. So, and this leads to objective sleepiness problems, you know, lower mean sleep latencies in the multiple sleep latency test. Here is it's a Laberge work, and it's a very interesting table where we can see the typical sleep-related features of patients with DM1. So executive daytime sleepiness, long nighttime sleep that is most of the time unrestorative. This is one of the main points here. Sleep-related breathing disorders, as I said, obstructive and central apneas, and so here is a very good list. I mean, I guess you will receive the slides so you can take more time. But so this is pretty well described, you know, so far. And there is also subjective sleepiness, which is more actually my interest more than sleep patterns, being a psychologist, a neuropsychologist. So what we see here is high levels and high percentage of patients, as I will describe here. So the main feelings that are most of the time expressed by patients are tiredness, weariness, or difficulty concentrating or pay attention during the day, a need or a desire to sleep during the day. And there is two kinds, you know, of this need, depending on patients. Sometimes they are able to resist and to not fall asleep, what is called resistible sleepiness. And sometimes this desire is so strong that they are unable to resist and they fall asleep. And I put here in italics, falling asleep suddenly and without warning during the day, sudden sleep attacks, it's more rare. So, you know, it happens in DM1, but it is more rare. Most of the time they feel, you know, that it's coming, and it's just an irresistible sleepiness that makes them sleep during the day. Situations of occurrence after meals. I mean, it's pretty famous for everybody, but in DM1, it's you know, very difficult to stay awake after meals. During undemanding or repetitive situations, this is a very frequent situation expressed by patients. You know, so watching TV, I mean, reading newspaper is not very common, but you know, if there is, you know, reading, watching TV, or even traveling, of course, because again, as everybody, traveling is something that is that makes you snoozy. And during demanding situations, again, I put it in italics because, again, it is more rare. Of course, you know, a proportion of DM1s will experience it, but another proportion frequently tell me that no, if, you know, it's a demanding task, if they are stimulated, they will feel tired, you know, like they will be fuzzy, they will have difficulties to concentrate, but they will not fall asleep. Clinical aspects. Reduce my screen. So here is, you know, prevalence found in some studies. Again, I'm not exhaustive in the references that I put, sorry about that, but basically you have 33% of DM1 patients presenting EDS, excessive daytime sleepiness, measured or by the April sleepiness scale or daytime sleepiness scale. But I'm talking here about actually studies from my group in Saguenay with a big amount of participants. You know, the N is 200 or 157. So I think we can trust, I guess, these proportions, these rates that we found there. And if we look at surveys, you know, so this is not a clinical assessment of EDS, but it is one or two questions asked to patients most of the time by mails or over internet. So, and in this situation, what they found, Heathwell and its team found that 88% of DM1 quoting yes to impaired sleep or EDS. And among the long list of symptoms that patients can experience in DM1, EDS was the fourth most important complaint and the fifth greatest effect on DM1 participants' life. So it brings, a good idea of how it impairs life. So let's keep on going with the literature. What is clear also is that there is subjective fatigue. Fatigue, there are several definitions and because several situations where when it can appear. So physiological fatigue can be described as an exercise-induced reduction in maximal voluntary muscle force divided into peripheral and central components, depending on where the loss of capacity is located. And you also have experienced fatigue, which is an overwhelming sense of tiredness, lack of energy, and feeling of exhaustion. It could be mental, physical, or both in same patients. And is not obviously the same as muscle weakness or muscle fatigability. Depending, again, on the studies, sometimes there is a relationship, sometimes there is not. And pretty interesting, it could appear after, during, or even without any kind of task or activity, this experience fatigue, which makes it very particular because, as you know, in normal, I hate this word, but people without affection, most of the time, if we're fatigued, it's a reward. It's a reward to a great effort that can be followed by, self-esteem or pride and whatever. But in this case, when you are fatigued and you haven't done anything, there is no reward. There is no positive impact of this fatigue. So, and this is something that many patients told me during my experience with these patients. So, what the studies say? 74% are severely fatigued as measured by the CIS in a Kalkman study, and they had more studies. This team, and it's all it's been pretty the same amount every time. So, to make it fast, let's say that this is between 50 to 75% of the participants that are assessed as clinically severely fatigued, depending on the studies and depending on, of course, the instruments that you use. So this is why, it could be important for you or not, but I've tried to put the number of participants and the instrument as well in this presentation, so you can compare, okay, which study should I not trust, because they are all trustable, but it gives you an idea, and we will come back on the outcome measures later on. Again, we have two published papers about surveys, and they are, again, very interesting. Of course, you won't find the same amount of symptom, the same frequency, depending on if you take, a classical instrument that are, validated and are multi-systemic of fatigue, and a survey with 1 or 2 questions. But still, it is very important because you have a great idea of the prevalence and the impact in patients' life. So in the Ethel study that we saw 2 or 3 slides before, fatigue was present in 81% of US DM1 patients that have been enrolled. And this was the second most important complaint, and it has the greatest effect on DM1 participants' life. So, usually when I talk about fatigue in DM1, I always say that, even though DM1 is a muscular disorder, the first symptoms are muscular weakness, myotonia, but if you ask patients, most of the time, the main complaint will be fatigue. In another survey, it was present in 79% of UK patients this time, and it was the most frequent symptom. Mental fatigue or fatigability, well, I'm sorry, I put one of my own studies just because mental fatigue, cognitive fatigue, or fatigability, you know, it is an aspect that hasn't been studied so much. And during actually my PhD dissertation, I made a study about that, and I felt it was interesting to tell you about it, because what we did is we had a 1.5-hour cognitive battery, of course with pauses, but still it's very demanding cognitive effort, and we assessed fatigue and energy before and after this 1.5-hour cognitive battery in 23 DM1 patients, compared with 19 FSHD patients and 20 controls. What we found, it's very interesting. Of course, if you know about cognitive performances in DM1, but with no surprise, they had a significantly poor attention performances, and really mainly, slowing in attention speed abilities. But there were no objective mental fatigability. If I will say so, objective, if we look at the performances in this very specific data selective and sustained attention test, which means that there were no decrease in performance along the test. It would have been, expected. For example, in traumatic brain injury, you can see that most of the time the performances are getting lower during the task. So you can say that there is a cognitive fatigability, So, but here, no, and there are no subjective mental fatigability either, which again is very interesting. No significant decrease in subjective fatigue and no increase in energy levels described by the patients. So here are the results. I'm not going to talk about it during a long time, but as you can see, there are no difference between T1 and T2 before, after for DM1 patients, and no difference in FSHD and controls either. For energy, it's very low in DM1 compared to the other groups, but also there is no significant increase or decrease in energy when there is a significant, I didn't put the sign of significancy only for intergroup comparison, sorry about that, but there is a significant difference for FSHD and controls where there is no in DM1, which means that there is a lack of mental activation. It's very, very interesting. And it may be associated with the very low attention speed performance in the test, observed in the test, which means that the patients, they are very slow. They don't do many mistakes, which is again very interesting considering the executive, deficits that they have. But they are so slow that maybe they work the task at an underneath, level of what they could put. So maybe we could interpret it as a no struggling coping strategy, but there are, several questions that we are asking ourselves. So do they don't draw on their resources and they can express it sometimes? They say that I know that if I put too much effort in a task, it could be physical or mental, I will be, so exhausted after that. So maybe it's an adaptive adjustment preservation strategy, or maybe they just don't have resources to put, as a mental activation in the cognitive task, and that could be related more or less to C central activation failure observed. I don't want to go that far because it's very tricky and complex, but it makes me think about it. Anyway, so this is the only paper really about, I mean, it's not a paper, but the only study on cognitive aspect of fatigue. And I think there is a great interest to go further for me or other researchers. What we see too is that EDS and or fatigue have a negative impact on, impact. I wrote that, but saying it, I want to be more, to be cautious about it. I mean, there is a relationship with depression, personality traits, interpersonal relations, and quality of life, social and pro participation, as we're going to see right now. So sorry about this slide. It's big, a lot of writings, but briefly, there are many studies saying that or EDS or fatigue are accompanied with other, difficulties. So the first one is greater pain in legs. This is again interesting, and I don't know if there are many other studies going this way, but it should be interesting to dig a little bit more. And but for the rest of what I've been writing here, as you can see, it's EDS associated with lower quality of life, fatigue associated with personality abnormalities, depressive symptom, lower health-related quality of life versus patients without fatigue, which is very interesting too. And I don't know who's the the attendance to this, so I don't know really where should I go more and more. But the relationship fatigue and depression, it's interesting, but it's tricky. You know that statistically correlation doesn't give you causal way to interpret. So you don't know. Is it because and many patients told me that being fatigued every day, after a while, it leads to depressive symptoms. But of course, reversely, you can also say that if the person have depressive symptoms for other reasons, fatigue is one of the symptoms of depression. And also in depression, you have a negative bias. So you see the world, how can I say, darker than if you're not depressed. So maybe also fatigue, self-rated, maybe it's overrated. So anyway, we don't know where is the link precisely, but still there is an association with between this and that. The only thing I would say to try to make a demarcation in this is that if you see the proportion, you have 70% of DM1 patients that are severely fatigued, but depression, most of the time, it's about 10 or 15%. So this is in favor of maybe, great fatigue close to DM1. And in some patients with some vulnerability, emotional vulnerability, maybe fatigue leads to depression. This is how maybe we can interpret it. But anyway, so another interesting thing is that depending on studies, most of the time fatigue is associated with everything: lower quality of life, more depression, and EDS. Sometimes yes, sometimes not. I think this is what we should, remember about this. But at the very bottom of the slide, you can see, and I think that for clinicians it's very important, EDS has been found to be associated with lower employment rate. And it could be explained by, a quote that was frequently remarked by Hilton Johnson and his team. It was that falling asleep at work, prevent DM1 from remaining in employment. So, DM1 in employment, it's a very tough question. They have many reasons to not maintain an employment, but EDS and fatigue, unfortunately, are one of them. So EDS and fatigue seem to impinge together or separately on DM1 patients' quality of life, social and labor market participation. It is an important source of unpredictability in daily life. It can freeze plans and spontaneity. So this is more what I would say, you know, after seeing DM1 patients during a long time clinically, is that most of the time this is what is questioned about by patients or by partners, you know, saying that because, and actually it is said underneath, because fatigue is like a roller coaster. A patient told that in the Copenhagen great paper. Some days I am in luck in all the days, the next I am not able to do anything, and then I can feel depressed, you know. It is said here, because it's not predictable, most of the time patients and their family, they just quit on making plans. So sometimes if patients and the family are flexible enough, they will try to be spontaneous, you know, like if one day I feel better, oh, okay, so what do we do today? I feel good. But most of the time, unfortunately, it's not working like that. It is more like, I'm very tired, I'm not going to do anything. Oh, today I feel good, but should I really start doing something? You know, so this is one of the main problems related to fatigue, in my opinion. So still clinical impact of EDS and fatigue. There is another quote, when I walk and then tired, I walk as little as possible. So, you know, this quote just tell us that fatigue is, I mean, real for patients and onerous, and it can lead to diminished activity or even in some patients, avoidance of activities. So there are many things that are pretty clear, and there are also many things that are not so clear. I mean, I'm not, again, a sleep laboratory expert. So I guess these experts have to deal every day with these facts that are not so clear, but for them, maybe it's more clear than what I can do from outside, just looking at the literature. But there is still questions about you know, SDB and objective sleepiness, and, you know, sleep disorder briefing, and this reaction, also the SDB and subjective sleepiness, because sometimes treatment for respiratory problems have a good impact on subjective sleepiness, sometimes not. And this is because, as we said, it could be central or sometimes respiratory problems, or both in the same patients. The link between objective sleepiness and subjective sleepiness is not so clear neither, because not only for the reaction to treatment, but also in the literature, the correlations or whatever, sometimes it is not that clear that they are really associated. Subjective sleepiness, subjective fatigue, it's not clear there. And about fatigue, subjective and objective fatigues, it's still very unclear, and particularly in DM1. There are this work from the Netherlands, I mean, many studies that led the team to a model of fatigue and social participation in FSHD and HSMN. But what the authors said is that, whoa, we found this model, but it's not working that well in DM1 patients, you know, most of the time, because actually there is such a discrepancy between the objective measures and the subjective measures that it's not only a problem of lack of awareness or cognitive impairment, it's also because they feel something that is not explained in the objective measures. So, and even the pathogenesis of EDS and fatigue are not so clear. So let's talk about apathy now. Well, why do I talk about apathy, talking about fatigue and EDS? Maybe it's just it's just because of me, but I think that those three symptoms are kind of a triad, you know, of I would say CNS related, even if fatigue is not only CNS related, I have to admit it, but kind of CNS, neurobehavioral symptoms that are very, very, frequent and important in DM1. This is why now I have the use to talk about the three symptoms altogether, even though you can see that I have separated EDS fatigue on one side and apathy after that. But so what is apathy? Basically, it's a reduced or a lack of, depending of which definition you find, but let's say reduced motivation, initiative, interest in activities, care, novelty, social life, and reduced emotional responses. It leads to, of course, reduced again and or routine activities, so reduced level of activities. And even those activities are preserved, they are more routine, you know. It disrupts healthcare, notably because it could lead to treatment non-compliance. I mean, it's not proved, you know, there is no study about it. But when you understand fatigue and when you know DM1 patients, there is at least an hypothesis, you know, I suggest that there is a link between this and non-compliance or lack of self-care, you know, and lacking interest in their own, follow-up care that many clinicians know what I'm talking about in DM1. So maybe, maybe it's not only because of apathy, of course, but I think there is a role to play in this. And this is a source of distress among couples, because most of the time, apathy is not very, how can I say that? There is a lack of awareness, which is actually one of the apathy dimensions, but they are not aware that they are apathetic. But partners, they do, you know. So this is why I put this sentence. And there is a great study about that by Cup, man with a DM1 saying, well, if my wife suggests, shall we go on holiday? Then I say, okay, you say where, because I don't care. She does not like that. I mean, that's very funny, because here he is aware that he is apathetic, and he is aware that his wife doesn't like that, but there is no change apparently. And the woman partner, not the same, I guess, but what can be postponed, what was postponed, it completely irritated me. So I don't know if it is the partner of the man before, but it could be or not, but this is very common, you know, partners saying that they have to lead everything in the couple or in the family because of apathy in DM1 patients. So what the studies said, there are not so many studies on apathy so far, but Van der Velden made a meta-analysis study, and the pooled prevalence would be 55% of patients, which is a very good rate when you are clinically experiencing these patients. But of course, it's a mix of phenotypes, so we just have to make it clear in the future of which phenotype has a more greater prevalence, or it is the same. But so we made a study, and in juvenile and adult phenotype, and we found about 40% of the participants with one scale. And we found that apathy was associated to the mental status, And we replicate a common study, but with more neuropsychological tests, and it's still in course of publication, but we found a really great association between apathy and cognition. And apathy, interestingly, would not be associated to fatigue, neither with depression or anxiety. So in our study, but also in 2 previous studies, which again, I say it's interesting because if you ask patients, they would say that they're fatigued, and this is why they diminish the level of activity. But if you also assess apathy with very validated interviews, you will also assess a reduced activity. But when the 2 scores are put in the statistical analysis, there is no association. So again, there is more studies to do to understand with this phenomenon. And apathy is associated to lower quality of life. Okay, treatments and interventions now. Again, not exhaustive at all, very fast. Of course, nocturnal, non-invasive mechanical ventilation is first mandatory, but well, it's sometimes it's difficult for patients to be compliant, and sometimes EDS persists. So it is important, but I guess we also have to bring more options. So psychostimulant could be one, and there is no consensus. There was a study on methylphenidate that found a significant positive effects on EDS. I mean, on subjective EDS rated by patients with measurement instrument, but no significant effect on objective sleep with the mean sleep latency test. Modafinil, another option, and no significant effect was found on an objective test by a French team, where positive effects were found on the same test by another team before. So, this is why there is no consensus. You have different results for different studies. But still, there have been a change many years ago when modafinil in Europe was, I would say, withdrawn because the situation is not the same. I mean, it's different depending on where you live, but still it's not as easy to prescribe than it used to. And there is it's Elton John's study. Sorry, I should have referenced it. And it was a very interesting publication because they asked patients what would change if they don't have modafinil anymore. And so there are many quotes, but I put some of them here. And it would severely impinge upon my ability to continue working full-time and adversely affect my capacity to parent my children. My quality of life would be extremely reduced, if not completely. Would not be able to work, drive, no family or social life. My husband has noted how much brighter I am through the day, thanks to modafinil. So what we understand here with these quotes, it's how much it's important for these patients, but also we understand something if we go a little bit deeper, most of the time, the most active patients will benefit from psychostimulants because actually they can do more, they can do more than what they can do without the drug. But they are active, they have children, they want to work, and they will have to face maybe part-time instead of full-time. So again, it is one part of the DM1 clients or patients that we can face. There are all the patients that may benefit from psychostimulants, but they are less active, you know. So for them, it will change that maybe they will sleep less during the day, but you know, is it very how prominent for them? I don't know, and nobody to judge it, but we can see how different are DM1 patients sometimes, more active, less active. So now there is no non-pharmacological, sorry, interventions, and one of them was this huge study with 10-month cognitive behavioral therapy plus optional graded exercise therapy for one part of the participants, not all of them, in severely fatigued DM1 patients. Very interesting. And the CBT group, of course, you know, felt the improve. I mean, of course, sorry about that, but there was a significant improvement in fatigue levels. So that was very very exciting. Minus 7.44, which is a good amount of change, and also it's followed by significant changes in activities and the level of activities. So this is very important too. But interestingly, there was no change in apathy levels. Then there was another intervention, but it's a preliminary study, a feasibility study, a 12-week strength training program in lower limbs in non-severely fatigued. I mean, some of them maybe were, some of them maybe not, but at the beginning, but it was not a criteria for entrance. So, and actually they were pretty motivated, so maybe they were not so apathetic at least. But the performance in strength and functional tests all significantly improved by week 12. And because it is actually a team included in our group, the research, I participated in this study, but not to the strength training program. What I took the occasion to assess fatigue, EDS, and apathy during this intervention. So before, during, and after. And what we observed, I mean, we observed actually a significant decrease of symptoms of fatigue and EDS. It came, you know, after, you know, the second part of the program mainly. So, which is still exciting because actually the program was expecting this kind of change. So, and the good, you know, the good news is that the effect was maintained after 6 months, sorry about that, 6 months, which means that, you know, I put a black sign here. This is the end of the program. And then we just, you know, asked them to come after 6 and I mean 3 and 6 months. And the level of EDS and fatigue was as low or even lower than it was at the end of the program. Pretty the same thing for apathy. We didn't assess them during the the program because the assessment of apathy requires change for at least one or 1 month and a half. So we just did it before and at the end of the training program, but the change was very significant. And again, good news, 3 months and then 6 months after the end of the training program, the effect was maintained. So this is only a small amount of participants, but just think it's encouraging. And more than everything, it's interesting because yes, assessment tools told us that you know, there was a decrease in the symptoms, but patients also, you know, their self-perception covered domain of physical, functional change, but also psychological. And you know, they said that they were they felt more energetic, and but also more self-confident, proud, and a better morale and enthusiasm. So they really wanted to be more active than before, thanks to the feeling of being stronger and more, I would say, more sure about their abilities. And to finish, assessment scales. So there is a great debate about which tool is better, or better in this situation. So I put here kind of a resume of what what is used so far. So EDS scales, Epworth and daytime sleepiness, fatigue. We have the Krupp fatigue severity scale, and also some teams use the Childer CSF and the CIS fatigue. It's a checklist inventory scale. And also the fatigue and daytime sleepiness scale, which is a scale developed based on the other scales that you see. And so it has been developed and validated in DM1 patients for DM1 patients. So psychometric properties, DSS, daytime sleepiness and fatigue severity scale, the internal consistency in DM1 was high. And the ESS, the Epworth, which is a famous scale for specialists in sleep, ESS, it was weak in the DM1 population. Talking about test-retest reliability, which is a very important property, again, DSS and FSS were higher than ESS. Daytime sleepiness scale. If we look at clinical / psychometric aspect, we see there are two studies of the natural history, the evolution of these symptoms, and the level of daytime sleepiness increases in a 9-year study and also in a 7-year study, Laberge and Perick, and but not the proportion of patients. So, I mean, this is interesting among psychometric aspect. It means that during 7 to 9 years, how can I say that? Sorry, because I hear something in my head. But yeah, I mean, it means, sorry, that the same patients were had excessive daytime sleepiness, but this level of EDS increased, which is not exactly the same for fatigue. I mean, it does increase, but also the proportion. So it means that fatigue levels increased, but also there are new fatigue patients during this lapse of time. Wait, I don't know why I hear a lot of noise, sorry. So DSS and FSS are sensitive to long-term clinical change. What about the sensitivity to change during treatment? Actually, we see that DSS and ESS have been used, but DSS was more sensitive than ESS. Let's talk now about the FDSS. There are a good intra-rater reliability, the test-retest, an ECC of 0.83, which is good. Acceptable internal consistency. And the FDSS was able to distinguish between fatigued or somnolent versus not fatigued or somnolent. So this means that there was a good construct validity. So to conclude on this part, FDSS is a 12 items that showed good construct validity, acceptable to rate reliability, and some items are questionable clinically, because sometimes items refers to being in a car or reading, which is not usual or common in these patients. So sometimes they have to say not applicable, which is not very interesting when you try to study fatigue and EDS, but still it is a good tool because it seems sensitive to change in non-pharmaceutical treatment, both in the Russell one and the Okerson one. So there is another option, which is the DSS plus FSS. So you split, which has been shown to be not very important in DM1 patients, because most of the time, excessive daytime sleepiness and fatigue can be put together. I don't totally agree with that, but still, this is an option. It it leads you to 14 items, and you can allow fatigue and EDS separately. So you can do whatever you want, but here are the the data. So apathy, there are less outcome measure studies, and we performed one with the AES that showed good internal consistency, and the scale, the self and the informant scale version of this scale showed good test-retest reliability, but it showed no significant change during the Okerson study, the optimistic study, which is strange because level of activity actually increased. And but it has been sensitive to change in the program that I was talking about. But again, it was a small, the sample size was small. And the Lille apathy evaluation scale, which is a scale that I've used in the past, I still think it's a very interesting instrument to use in DM1, but there is no psychometric studies in DM1 so far. Okay, so I don't have any conclusion for that, but thank you very much for attention, and I will try to answer the questions as much as I can. Thank you very much.
Thank you, Benjamin. It was a very interesting and rich communication. We have questions, yes. Mário Gomes Pereira, you can talk if you unmute yourself and voice your question.
Okay, I have. Hi, Benjamin. I had a quick question, maybe I missed it. Are there any studies, any longitudinal studies that show that mental fatigue progresses with age in the same patients, or has it never been done?
When you talk, when you say mental fatigue, do you mean, as I said, kind of cognitive fatigue?
Yes, yes.
No, there is no, as much as I know, there is no study, no longitudinal study about that.
Okay, thank you. And thanks for the seminar.
Thank you, Mario.
Okay, so Elizabeth Erokina, do you want to unmute yourself? You're about to talk, so if you unmute yourself, you can ask your question live.
Yes, thank you. Thank you for great presentation. I have some question. What about sleep disorders and mental issues in children? And do children suffer from it, and how often?
Yes, this is a very good question. In children, yes, there is one study. I don't remember the year, but it's Kerasalva study, and yeah, I didn't put it. I could, but as I said, I focused on adults because why should I bring one paper? But your question is very good. So yeah, Kerasalva had a paper and showed that there was a very frequent EDS and sleep disturbances in children with DM1, and so I don't know if there are studies that I missed, and it's very possible on the effects of the, as you say, psychiatric or emotional impact of sleep perturbations in children. I don't know if there are studies, but in my experience, which is not that big again, because I was a clinician with adults, but I was in the Correa Salva team actually for a while in our lab, and I started to interest myself with DM1 because of these children. So as much as I know, yes, you know, they're, how can I say that? I can't say if there are any specific, you know, emotional disturbance or whatever, but yes, the impact was great on these children, which means that, you know, they felt fatigued and they fall asleep during the day. So it was very hard to cope with school. And first they have cognitive, you know, impairments, most of them, but again, if you add fatigue and sleepiness, yes, it was very difficult. But sorry about that, I don't have published data about on this.
Okay, someone called.
Thank you.
You're welcome.
I want to ask one more question. Can I?
Yeah.
Should we use the same treatment for children as for adults?
Oh, so this is a very good question, and I'm not the one to answer to that. I'm sorry. Sorry for the disappointment for people who thought that I was a specialist in sleep patterns. As I said, I made more work on the impact, but I'm not. I can't answer this question because this is not my role. I don't know if Antonio wants to talk about it, or anyone
I would
else.
say that some of the stimulants that are shown in the slides are used in children either for ADHD or for sleepiness, like the ones with narcolepsy. So I wouldn't exclude that hypothesis, and there's quite a literature on the subject. So it depends only on the restrictions that were recently made for the use of some of the substances. But in general, you can consider that and see what is appropriate in your country.
Thank you.
There's someone called Gigi with a hand up. So if you want to unmute yourself and speak.
Okay, bonjour Benjamin. Gigi is for Geneviève Gourdon.
Oh, bon.
Hello, Geneviève.
Well, thank you very much for
Bonjour.
this very nice presentation. So I have a question. You know, I'm not a psychologist, so maybe my question is a bit naive, but so I would like to come back to apathy and fatigue. So you mentioned that several studies have shown that there is no correlation between apathy and fatigue. Does this apply? Can we draw the same conclusion for the mental fatigue that you described?
Well, this is not, I mean, maybe it's a naive question, but it's a very good question. Yes, as I said, there are not enough data regarding cognitive fatigue, in my opinion. And again, maybe I missed some because it's very difficult to stay aware of everything in so much dimensions that I like in DM1, as you know. So maybe I missed some, but oh yeah, it's a very good question because as I said, I saw very important relationship and correlation between apathy and cognitive functions. So during the evaluation, we all know, I mean, we try to avoid the fatigue, the mental fatigue during our evaluations, but maybe there is a part of the scores, the performances that we get. Maybe there is a part of mental fatigability. So if I see a relationship between cognition and apathy, maybe there is a correlation between apathy and cognitive fatigue. You understand my reflection, but I don't have data to answer, but it's a very good question. Yeah.
Thank you.
You're welcome.
Okay, so if there are no further questions.
Yeah, and I'm sorry, I'm still thinking about it because it's very interesting. But yeah, Geneviève, you're right that, you know, the lack of mental activation that I talked about regarding my dissertation study, maybe this is apathy, you know?
Yes,
because apathy, yeah, exactly. It is known for the lack of initiation. Oh, sorry, we talked together. Sorry.
Oh, sorry.
Let's go.
No.
So yeah. One part of the definition of apathy is this lack of input in activities, and so there is at least a conceptual link between those two. I totally agree with you.
Mm-hmm.
Well, last question will be for Valeria Sansone.
So we have an expert of sleep here.
Valeria, can you unmute yourself and talk? Well,
she's on mute, but
yeah, I don't know.
I can't hear.
I can't hear also. All right.
And maybe, okay, it's too bad. Maybe she had a clue on the question, on the past questions regarding sleep and children. I don't know. Sorry about that. I mean, Valeria is someone who knows about this better than I.
Okay.
Anyway,
if Valeria is not able to log in, thank you very much, Benjamin. I think that the interest is demonstrated by the participation of the audience. And this webinar will be available on the ERN site on demand. So, and if you want to share your slides, I will do it through the website as well. Thank you very much once again. Very useful.
Thank you, everybody.
Helpful. Thank you. Bye now.
Goodbye.
Thanks.
Bye.